Hello, YouTubers. This is Michele, Cuke, yours truly. I'm going to look at the topic of retained placenta. And again, this is the way I learn. By talking about it, it lets me know if I really know what I'm talking about. And then it also gives my viewers an opportunity to critique me or add any other information. So I want to look at the topic of retained placenta, and I looked at this and have various notes. So it might not be so systematic, but the other advantage is when I listen to the video as I'm driving, it reviews the topic for me as well. So when we think about third stage of labor, and that's from the birth of the baby until the birth of the placenta, one of the most important things for delivery of the placenta is uterine contractions. So that's the power. That's what we want. It's the most responsible activity or needed activity, the uterine contractions for detachment and expulsion of the placenta. So there are different ways that people or practitioners manage third stage. There's an active way, active management, where they deliver Pitocin, and this would be routine. And right after the delivery of the baby, some people will do it right before the baby's delivered, and then gentle cord, controlled cord traction. So that's active management. And if it's done, a lot of times the placenta will come between 5 and 10 minutes after the birth. Expectant management, it should take about 15 to 30 minutes. And you're waiting and letting it happen spontaneously. I have the tendency to favor that. They claim that studies show that active management of third stage labor results in less bleeding. So, you can review that in case you have a test question or something on that. So what is a retained placenta? How long would we, wait, or would we consider it considered to be retained? And that would be 30 minutes after the birth. Now I work with preceptors who do home births, and we would think nothing of 30 minutes. I mean, we would wait an hour. And you can do that. You can wait an hour if there's no bleeding, the client is stable, vital signs are stable. You can wait, but the belief is that if it's longer than 30 minutes, it's considered a retained placenta. And even if you're willing to wait, you want to evaluate and see if there's reasons for it. Why is it retained? So one of the main reasons is atony, where the uterus is not contracting adequately. And so, your measurement then would be, or your intervention then would be to get it to contract. So there are different ways to do that. There's nipple stimulation, either by putting the baby to the breast, or if you have a toddler that's still nursing, or a partner, or the breast pumps, or even with your finger, but that would release oxytocin, which would cause uterine contractions. An injection of Pitocin, a synthetic form of oxytocin, can help with contractions as well. And I believe Varney talks about different manipulations that you can do with the uterus, putting your hands, on the top of the uterus and kind of gently moving it back and forth and side to side to get it to, stimulate. I'm not familiar with that too much, but that was mentioned as well. So the number one reason you can have a retained, I shouldn't say the number one reason, because the number one reason for postpartum hemorrhage is atony, but for a retained placenta, I'm not sure, but we want to look at the uterus and see if it's contracting. The other problem is that it may have detached and it's trapped inside the uterus. Sometimes there's constriction rings that develop that trap it a little bit. And so you would want to check for that. I'm not 100% sure how. I believe you can follow the umbilicus and see all the way into the vagina to the cervix and see if you can feel the placenta. Part of it could be out and then it could be constricted possibly. So in that case, you want to try some way to relax that constriction. You know, you don't want to stimulate the uterus. You want to do something that would cause it to relax so that you can get the placenta out. So it could be trapped, okay? Clinically, the uterus can be contracted, but the fundal height will be more because of the trapped placenta. Sometimes it could be, which is rare, it could be adhered to the muscle rather than that inner lining, the decidua, rather than that, it could be the muscle under it, and that's accreta. And then there are different levels of accreta. It could go, you know, depending how much that placenta has penetrated those tissues, in which case, you know, they would need medical intervention of some sort. It could be some type of surgical or a procedure to release that. Accreta isn't something that you would be able, the midwife would be able to do that I know of. Sometimes, you know, it's adhering, but it's not an accreta. And again, that goes back to possibly the uterus not being able to give adequate contractions. We want to be really careful because sometimes the placenta can partially detach and you're going to have bleeding, and then that becomes something that immediately you have to do something about. If there's an accreta where it's fully attached and it's not detached anywhere, there won't be bleeding and it won't be so much of an emergency. But if it's partially detached and you've got bleeding, then you're going to have to stop that bleeding. You're going to have to do something about that. So let's look at some risk factors that can come with what would put someone at a increased risk for partial separation of the placenta or with uterine atony. So a history of it, a previous history of a retained placenta, poor contractions of the uterus, premature contractions of the lower segment of the uterus, when uterotonic drugs were used to induce or augment labor, it could lead to a tired uterus, a prior uterine scar, if there's fibroids, a stillbirth where the baby was in the uterus for an extended period of time. So those could put someone at increased risk. Premature labor, the placenta is adhered a little stronger, and that kind of makes me think of a fruit that's young, you know, like a banana that's too young. It's hard to open, you know, and so premature labor, that placenta is not really ready to detach, so it's a little bit harder to do that. So premature labor, induced labor, fibroids, a multip. So these are things that put you at increased risk for a retained placenta. So as a practitioner, you want to have red flags. You know, if there's those that in their history, you're going to be more vigilant and anticipate these potential things. So management, and all of this is theory for me. Okay, I haven't really seen a retained placenta. I was at one birth where the client had a history of bleeding, and I remember the midwife just went in and manually removed the placenta and started an IV, gave her Pitocin, 20 units IV and 10 units IM, and they just didn't waste any time waiting for it to develop. So I wouldn't say it was a retained placenta, but it was definitely a manual removal for that. Okay, if there's no bleeding and the vital signs are stable, you can wait another hour after the birth Okay, to wait. You can wait. You can give Pitocin IV. My understanding, well, I read that you can give it through the umbilical vein, but I feel like that's out of the scope of a midwife. Maybe it depends on what state you live in. I'm in Alabama, and to my knowledge, that is not an acceptable measure, but I'm not 100% sure. If there's bleeding, you must act immediately. You have to do something. So, this particular video from a physician, she said, manually remove the placenta. It's an aseptic procedure. You're making your hand in the shape of a cone. You're entering the vagina, following the umbilical cord, go to the edge, and then you kind of work your way with this kind of action to peel off the placenta and remove it. It should come off easily. You shouldn't have to force it. Like I said, I've never seen this done, and in most of the literature that I've read, you're supposed to give some kind of painkiller, and it's supposed to be done like in a, hospital setting. And so, like I said, I've seen it in the home setting, but my understanding is that it's painful, and they maybe need pain relief. But if you're trying to save someone who's bleeding out, then you want to be able to do that. Of course, you want to give Pitocin after removal. You want to make sure that that uterus is nice and firm. Sometimes the uterus is firm and they're still bleeding, so you want to check for perineal tears, injuries, or the placenta is not totally removed. You want to deal with the bleeding. You want to get good lighting. You might have to use a speculum, and you want to find out where this bleeding is coming from. And it may be more than one situation, right? It could be left placenta fragments in the uterus and it can't really contract well, so there's some bleeding there, and it can be perineal tears as well. So you don't want to just be, I got it, you want to look and be careful to make sure that you've identified all of the areas of bleeding. So, like I said, with manual removal of the placenta, it would be an emergency, is what you would do if there's partial separation of the placenta and there's bleeding and you're not able to control that bleeding. Then you would want to get that placenta out of the uterus, because as long as it's there, then those sinuses are open and there's going to be bleeding, and the uterus can't contract and do its job. So anything in that uterus is going to interfere. My understanding is if the membranes are left in there, it's not as bad as if the placenta fragments. So when that placenta does come out, you want to check and make sure that it's completely removed. It does say that they need anesthesia for manual removal and antibiotics. So again, do your due diligence and study this further to have clarity, the protocols for who you work with, and what needs to be done, and what your scope of practice can be. So what are the risks when you do manual removal of the placenta? You may see it in the literature as MRP, potential infection, potential injury, bleeding, and sepsis. So there are, and uterine rupture. So there are potential side effects. You want to know the signs of placenta separation. You want to know what you're looking for. So you're going to look for a different shape in the uterus. It's going to go from more of a flat shape, discoid, to a globular, more round shape. After the baby's born, the uterus is just like a finger breadth or right there at the umbilicus. When the placenta has detached, it will be a little above the umbilicus. There's a gush of blood, and there's more blood with the Matthew Duncan delivery type of the placenta. When the baby side the mother side comes first with the Duncan, dirty Duncan. because the blood is free to flow. With the Schultz, or the shiny side, if that comes first, then sometimes the bleeding is behind that. So there's more bleeding, but usually a gush of blood, a permanent lengthening of the umbilical cord. So about 3 inches. You see it get longer and it stays that way. That's a really good sign of placenta separation. Now, prior to, I haven't heard of this one except just recently in my reading, but prior to the separation of the placenta, the baby is born. If you try to do, the uterus is not ballotable, you hit it on one side and you won't feel it hit the hand on the other side. But once the placenta is detached, it's ballotable. And I imagine because that placenta is coming on the other side. So that was something new for me. So the uterus is, it becomes ballotable. And those are the signs. So you want to know the signs so you know when it's detached. So there's all kinds of emergency treatments or remedies that I read about. I have an old book, and it talked about in an emergency with bleeding, you can give a half a teaspoon of shepherd's purse tincture, mistletoe tincture, and false unicorn. And you could put those tinctures in 2 to 3 ounces of water. So I'm not familiar with any of those tinctures except shepherd's purse. I know that to stop bleeding. Mistletoe was kind of new to me, and I wasn't able to Google anything and find anything about that. But mistletoe can be used to cause uterine contractions. What I see more is cotton root tincture. I see that used to help with the contraction of the uterus. Cotton root bark tincture, a dropful every 15 minutes. And so maybe those have taken place of the older ones. Maybe it works a little bit better. So let me read this to you. Manual stimulation of the placenta should only be done if there's bleeding and the placenta is not coming. Even when done, do it slowly, moving it back and forth and side to side with the hand on the fundus. Vigorous kneading or fiddling with the fundus can lead to a partial separation of the placenta, which would lead to more bleeding. Even after the placenta is delivered, you want to be gentle because vigorous manipulation can lead to disruption in the clot formation at the placenta site. So just be gentle. I've worked as a nurse in maternity centers, and they're kind of rough with the massaging of the fundus. And, we don't need to be rough, okay? Remember, if there is bleeding and the placenta is not delivered, the first step is to stimulate the uterus to contract. So you've got oxytocin, we've got the rocking, we've got the herbs, we've got nipple stimulation, cotton root tincture, mistletoe I have heard about, baby to the breast, older child, or some way to do nipple stimulation. If there's still bleeding and the above doesn't work, then you're going to follow the cord up to the cervix to check for detachment. The placenta could be detached and just, it needs to come out so the uterus can clamp down. And then, of course, you may have to remove it in an emergency. Concealed blood, bleeding behind the placenta, you want to check for that. Excessive bleeding can occur behind the undelivered placenta if you are not watchful. This happens when the detached or partially detached placenta blocks the os and prevents the blood from coming down. So the placenta is detached.